Thank you. I must thank Rajesh really to give me the opportunity, and this is a unique opportunity because I think, in general, NGOs and public, they think the trusts and the NGOs should be doing something to support the patients, either emotional, financial, and otherwise. But somewhere in our country, we didn't have this support to research from the private and public institutions, and especially the NGOs. And I think that's very important. And Rajesh, thank you for inviting me to give this talk. In fact, in 72, I went to US, and then I came back to India after US and Canada in 85, joined Apollo Hospitals as an oncologist. And in 93, we opened this first corporate cancer hospital in Apollo chain in Chennai. And that was in 93. Then I started looking at a lot of patients and found our patients, the disease behaves different and the treatment behaves different, either in the responses or the toxicities or anything. And this is totally different. And I was kept worrying and wondering what's happening to these patients when I'm doing all these modifications for treatment, because the patients cannot tolerate certain things and the disease also behaves different. So I developed a software for myself, and I in fact collected about 400 and odd patients. And these are the 400 odd patients. As you can see, the bottom is, it goes up to 216 months follow-up. That is nearly 10, 20 years now. From 99, I've been looking at these patients. And as you can see, the T1, that is less than 2 centimeters size of the breast cancer, that was the top line. Even at 20 years, they are about 95%, surviving without disease. And the other two are, the next line is 2 to 5 centimeters, and the third line is above 5 centimeters of the size. And even today, when we look at the average size of the tumor in private institutions, it is still 3 centimeters. So we have to somewhere bring it up to the 2 centimeter level and below. That is important. That's public education that we need. But then we started looking at it, and I said we need more numbers to confirm all these things and look at the several things. It's not just 400, we need 4,000 of these. So I started developing further softwares, and people wanted me to do we did for lymphoma, and then they wanted to do the whole thing. So finally we did develop a software called OncoCollect, and I also created a trust, RNCF, which is actually owns the software, and it is given to the institutions. Depending on the institution, as Dr. Ajay said, some will support the trust, some doesn't have to support. Still, they will get the software to do that. And these are the institutions. The software is already installed now. As of yesterday, in fact, Cytocare is in Bangalore is also part of this now. And in this, the top one, the Rajiv Gandhi Cancer Institute, and the Mahavir Cancer Institute in Patna, and Saroj Gupta Cancer Institute in Calcutta, and Indo-American Cancer Institute in Hyderabad, all the four decided they will put all their data together. And that is what we have done at the present time, and I'll show you a few things. And this is in these 4 hospitals, we have about 820,000 patients' registration data. That is, we have demographic data for these patients. And in Mahavir Patna, we didn't have the coded primaries, so we removed that, and there are about 317,000 registrations between the 3 hospitals, where some coding is done for the primaries. So when we look at this, this is the yearly male and female from 2010 to 17, and this is the age group. As you can see, the females come down after 60, and that is because most of the breast cancer in the country still is below that, and after that it is males, other diseases. And these are the primaries we identified. That is 190,000 primaries in these 310,000 registration data. That is about 70% of the primaries. And here you can see that, I don't know the point. Yeah, can you see the pointer? Hopefully you can see the pointer, but the left blue is the breast cancer on the top. That is blue is female, red is male, and left blue is the breast cancer, and next to that blue is the cervix cancer. And at Saroj Gupta Cancer Hospital, they have been collecting primaries from 96 onwards. So we have 20 years primary data from Saroj Gupta Cancer Hospital. I haven't put that slide, but there the cervix showed over the 20 years has come down from 45% in females down to 20% by itself, and there was no specific screening or anything done. So it is basically education of the females, socioeconomic improvement, hygiene, few things that happened across the country. And then now if we remove the gender-related cancers, this is what happens. Male are 2 to 1. 85,000 are male and females are 41,000. But the important thing in this is, you see this left red one, and that red one is head and neck cancer related to tobacco. And the next tall red one is the lung cancer related to tobacco. And there are few other cancers still related to tobacco. We know that esophagus, so many other cancers. But if you just take these two off alone, you can see what happens. Now, the nearly 200 plus 2,000 cancers came down to 83,000 once you remove the gender-related and the tobacco-related cancers. So the tobacco-related cancers, if you remove, you will have almost 50% of the cancers in the country are gone. And of course, we don't talk about banning tobacco, as Dr. Ajay Kumar said. In fact, I had a slide to say the only country in the world that has banned tobacco is Bhutan, and no one else. And we can be the great example if we can do that. And the farmers, let me say again, the tobacco grown, the fields, they are rich fields. So anything can grow there. It is not that only tobacco can grow there. So I think farmers is not the answer or the question. It is always the industry, honestly. And I think somewhere the public has to do. This is not government. Public has to push the government to do it. And this is where I think you can do a lot more, let me say, from that point. Now let me bring back that breast. Then now you see the females go up again. Why I brought this is cervix we removed, head and neck I removed, lung I removed, because they all can be prevented very clearly. And even some of the breast can be prevented by obesity and other things. In our country, for example, urban breast cancer rate is about 30 plus per 100,000. Whereas you go to the rural, it is around 15 per 100,000. So obviously it is lifestyle related once you come to the urban and women. Genetically, the pool is same. So obviously breast also can be prevented to a large extent, but by lifestyle change, not by some simple tobacco stop or something. So that is one. So these are all important. We know what it is. But then obviously these need treatment. When you give treatment, we need to see what the outcome is, what the costs are, what is the best possible. Because when we say, we follow the Western literature to treat our patients, it doesn't make sense because we're biologically different, and I will show it at the end what it means. Now this was the part of the study presented at Jaipur ISMPO conference by Dr. Senthil. Between Patna and in Hyderabad, they collected. We collected in 4 months, January to April 2017, 4 months, 600 patients of breast cancer between the two. These are the treated cancer. And when you look at the metastatic disease at presentation, it's only about 11%. And 5 to 10% is common anywhere in the world. And that cell is different. Nobody can do anything with it. We don't know why that happens. But the others are equal between the two. But then you look at this M01, what the stage in the M0 differences is. In one of the hospitals, stage what we call the locally advanced is 40%, whereas the other hospital, it's only 5%. This is the most difficult thing to treat, and the survival goes down. This is, in fact, not 5 centimeters. This is involving the skin. As I said, even at 5 centimeters, it goes down. And if we really want to get down to here, possibly at least to here, then we can. And that is public education. So that is where you can put in terms of the public education for the clinical stage to come down. Now, the next thing we found is that there is a difference in what we call hormone receptor status. This is 56% in this hospital, whereas only 25 here positive, and that's negative. So we need to look at what the differences are, because every place, we are not a homogeneous country. I will show you that again. But when you look at the treatment-wise, I think the doctors are trained all over same. In India, we have specialty doctor trainings, and it's pretty well standard to treat, how to treat, and it is being done. And you can see it is these two drugs, anthracycline, taxane, are the common drugs used. And between those two, between the two hospitals, most of them got that. And number of cycles given are also somewhat similar. There is no change. So in that summary, what we concluded is multi-center data is feasible. We can look at that. And there are some differences. We have to see why local differences are there. And metastatic disease is uncommon, and of course it's progressing. Next, this is a lymphoma group that is formed by Dr. Reina Nair from Tata Medical Center in Calcutta. At present, Dr. Reina Nair and Dr. Burani from Rajiv Gandhi, the two centers are part of this. And of course, as of yesterday, Cytocare is going to join as well. And the Indo-American and Mahavir have completed their ethical clearances, so it's going to be joining. And when we looked at it, just to present again at Jaipur, 1,500 from 2011 to 16, this is the distribution we got. And in this, from 2011 to 13, we had enough follow-up to look at the survivals of these patients. And when we look at that, this blue line, the bar, this is the age, the left side, the age of the patients. Older people have less complete response, males have less complete response, and the lower ones will have a complete response. So with this one, we looked at the response with people who had complete response, what is the survival in the age group? There is no difference. And these people have more than median follow-up of 4 years. So this is acceptable. So this can be done. Now let me show you a couple of slides really to say what this is all needed for. This is simple thing. This is not physiology, this is anatomy. As you can see in Haryana, they are making an Indian brain template. And this is to show that this is to serve as a guide to neuroscientists and surgeons who have so far based their knowledge of intricate brain anatomy on Caucasian models. Just imagine, a lot of people in the world, not us, believe there are significant variations in the location of key brain regions and the density of neurons in various brain areas between racial types. In fact, US, UK, and all had their own brain templates. That's what everybody uses. And in fact, China, South Korea, and Canada, some of them have already made their own brain templates. So now we are doing our brain template. So imagine if the anatomy can be different, something like in brain, what the physiology is, how our body behaves, either for disease or for the treatment or the drugs. I think that is most important to understand. And this is a publication from ICMR last year, 2016, disease burdens. And as you can see, what the bottom in Tamil Nadu and Kerala, 70% deaths are related to the non-communicable diseases. Infectious disease deaths are very limited. And the next up is the Andhra Pradesh, Telangana, Maharashtra and all, and they are about 60%. And the middle belt is still around 40 to 50% infectious disease deaths are there. So that is changing. So as you can see, in the country, there are differences. So we have to collect data from everywhere and then see what kind of change we need to make. We keep talking about evidence-based medicine. And evidence-based medicine is synonymous, unfortunately, in general terms, with the research-based evidence. But that is only a part of it. If that is the only part, then anyone who is graduated today or specialized, passed out today, we'll all go to him, because he should be the one knowing the latest. But nobody does that. You want the doctor to have 10 years experience before you see him, if you can manage. And that is because the experience is important. And of course, for us, not only experience, resources are also part of it. Across the country, resources mean not just the money. The resources means what kind of machineries, equipments we have, facilities, what kind of expertise we have. Not only the doctors, technicians, physicists, lab technicians. If somebody gives you a wrong blood count, you will end up treating somebody with chemotherapy with disastrous outcomes. So every level you need that. That is the resources. Depending on that, we decide at any place you practice in the world, you decide what to do the patient in front, sitting in front of you. And then you collect all of their data, that is the real world data, and analyze. And you make an evidence-based medicine for yourself in your practice area. You constantly improve it. You constantly try to change as you find the lacunae. But that is what needed. So to do everything at the end of it, we need our own data sets, every part of the country. Not from the West for the whole world, country, and even within the country, not from one place, but from all over the country, every place you practice. Thank you.